Hi, everyone, and thank you for joining our discussion today. And as always, for your partnership in the Research America Alliance. I know you've heard this spiel before, but if your organization is not a member, please do consider joining us. We can do more advocating for medical and public health progress with your assistance and as part of our team. So get in touch with Anne Mandeville, and I think her email is in the chat if you're interested in learning more. I'm so excited to introduce our guest today, Dr. Daniel Bausch. He's the president of the American Society of Tropical Medicine and Hygiene. He's also the senior director of emerging threats and global health security at FIND. And if you all are not familiar with this terrific product development partnership, it is working to develop diagnostics for some of the most treacherous global health threats out there. So it's a terrific organization. Dan will be providing a much needed update on monkeypox in the US and globally. As always, please type your questions into the Q&A box or the chat. We'll pose as many as we can during that portion of today's session. Dan, again, thank you so much for joining us, and over to you.
Yeah. Thanks, Ellie. Great to be with you. Thanks for the invitation. Thanks, everyone, for taking their time today. I'm going to try and in about 20 minutes give you an overview of how I see things and what's going on in the world with monkeypox. That'll require going into smallpox a little bit, because you can't really understand what's happening with smallpox. I'm sorry, with monkeypox, without also understanding the history of smallpox. And then we'll talk a little bit about what are some of the tools that we have to control this outbreak, and then some of the research gaps and knowledge gaps, or research needs and knowledge gaps. So first of all, monkeypox. And so this is an illness, the typical monkeypox. I think by now everyone has probably seen some photos of this. The typical monkeypox is a disease where you develop fever and headache and general symptoms for a few days, and some lymphadenopathy, so swelling here in the glands in your neck that we've all had when you've had a cold or common things. And then a rash starts to begin. And the rash initially develops and looks something like chickenpox that we've either had or seen pictures of. And then those lesions that are fluid-filled to begin with become pus-filled, and then eventually will crust over, become dry, and a person generally will get better. So that's the typical presentation of monkeypox. This is a disease that is endemic in areas of sub-Saharan Africa. It was first noted, actually, monkeypox is a misnomer. It was noted in a monkey that was imported from Singapore to Denmark in 1958 and had lesions, and the first virus was isolated. And then the first human case was recorded in 1970 in the Democratic Republic of the Congo. We recognize two distinct clades or strains of monkeypox virus. One is the Congo Basin clade or strain that is associated with a higher case fatality, with about 10% case fatality. And then the West Africa strain or clade associated with a case fatality of 1 to 3%. So the more virulent, dangerous one is the one that circulates in Central Africa. And up until very recently, this was something that I'll get to the point of, this is not how we should think of it, but then nevertheless, how we did think of it is something that was, unless you lived in very remote, rural places of sub-Saharan Africa, really wasn't your problem or anything that we needed to particularly worry about. And because those were the cases existed, that's where it's endemic. Its reservoir, again, is not monkeys. It can infect monkeys, but the reservoir, it's maintained in nature by probably small mammals. It's not completely clear, but different types of rodents. And humans generally get infected from contact with those rodents. Then once in a while, up until very recently, we've had rare imported cases into countries outside of Africa. And that is a traveler who's infected and then makes their way to London or New York or wherever it may be, gets sick there, is diagnosed with monkeypox, and usually gets better without much secondary transmission. You do have secondary transmission of monkeypox virus, that is between humans or human-to-human transmission. That occurs. This is a much different thing. We shouldn't think about COVID at all. This is a much different virus with a much different mode of transmission. So it's not an easy virus to catch. You catch this by having close contact, physical contact with a person for the most part. Perhaps in the early phases of the disease, there may be some transmission from a person who can be coughing, but only really if you have direct and prolonged contact. So much harder to catch monkeypox virus than it is to catch COVID, SARS-CoV-2 with just normal day-to-day interactions. And so then to understand, as I mentioned, to understand really monkeypox, you have to understand smallpox. And so smallpox virus, of course, is the only virus that we've succeeded in eradicating from the planet. There are just stocks of smallpox virus that are still left, or variola virus is actually the scientific name, that are left at US CDC and in Russia are the only two places. Those are just in laboratories. The world has not decided. It comes up periodically whether those should be destroyed, those stocks, but the world has not decided as such right now. So we were able to eradicate smallpox virus through a very good vaccine. Unlike monkeypox virus, one of the advantages, if you will, of smallpox, although it was more dangerous, the only reservoir for smallpox was humans. So we were able to focus on getting enough vaccine into enough people across the world, and culminating in 1980 of a declaration of eradication of smallpox. And so consequently, people stopped getting vaccinated against smallpox. And we started to see in the 70s and 80s and growing more cases, again, in sub-Saharan Africa, of monkeypox that was, if you will, filling the epidemiological niche. And so initially, there were very few cases of monkeypox because we recognized that from all the data we have, and I'll get into this in a minute in more detail, that it was smallpox vaccination that was also protecting against monkeypox. These are viruses in the same family called orthopox viruses. And so when we stopped vaccinating for smallpox, we started to see more monkeypox. And that's something that has been growing. The surveillance in Central and West Africa for this disease has not been great. There were long periods where no cases were recorded, but it's been increasing over the last few decades, and then some relatively large outbreaks in Nigeria over the last few years. A noted outbreak in the United States. Those of you who are a little older may remember in 2003, I believe it was, there was an outbreak of around 50 cases in the United States. That stems from, seems like a strange thing for people like me, but there are people who collect rare rodents and just have to have Gabonese or Ghanaian pouch rats or something like that. And so we have these small mammals that can be imported. And in this case, they were imported from Ghana and were co-housed or co-caged with prairie dogs that are also sold as pets. And so the rodents from Ghana passed it on to the prairie dogs, who passed it on to humans, and caused around 50 cases of monkeypox in 2003. There was no evidence there of sexual transmission. Most of the cases were in young children that, again, had the contact with these animals as pets. And after that, we really saw ignoring, which we basically did ignore, sub-Saharan Africa. We had a few cases of imported travelers, and but nothing really to note outside of sub-Saharan Africa. And so that brings us basically to today, where we are. And looking at the stats that I looked at just this morning, we're around 25,000 reported cases or confirmed cases of monkeypox in the world. That's probably a significant underestimate, because again, those are the people who have recognized disease, gone to a healthcare provider, had a sample taken, and had that tested. But 25,000 confirmed cases, 9 deaths across the globe. 98% of the cases so far outside of sub-Saharan Africa are in men who have sex with men. And I'll get into that a little bit more, and whether we can consider this a sexually transmitted disease or not. There's, we worried a lot about, and you've all been through this over the past few years, about with COVID, the variants of concern and the mutations of the virus and what that brings in making a new virus or a new variant of the virus that's more dangerous or more transmissible or not covered by a vaccine. COVID is or SARS-CoV-2 is a different type of virus. It's composed of RNA, whereas monkeypox virus is composed of DNA. DNA generally has a much slower mutation rates than RNA viruses. And so the concern of this virus being drastically different or going through lots of changes is much less. It's not impossible. There are some changes in the virus sequence, but I think it's safe to say that the data so far would suggest that what's happening is really driven much more by social and cultural habits rather than a new virus, that this new monkeypox virus that is different than what we've seen before. That's probably not the case as far as we can tell right now. It's more that this virus has just gotten into a certain population and situation that has facilitated its spread. And as I mentioned, that spread has been primarily in men who have sex with men. We should be clear from the beginning, this should not be associated with any particular stigma or accusing anyone. And it's not necessarily that we would say this is even, there's debate whether we would call this a sexually transmitted disease. It takes, as I mentioned before, it takes close contact for someone to get monkeypox virus. And so you can imagine that when people have a sexual interaction, they have close contact, they may still have close contact even if they don't have actual penetration in intercourse and still be able to pick up monkeypox virus. That would be the same whether the contact and the sexual interaction was homosexual or heterosexual, gay or straight. So I think we need to be careful not to characterize this disease as for one particular sexual orientation. It happens to have gotten, as far as we can tell, we will never know the first case of where this was initiated outside of sub-Saharan Africa. But I think the logical conclusion is that we had a traveler comes from sub-Saharan Africa who then in different settings with men who have sex with men transmitted the virus, some of them at Pride and other festivals where there can be quite a lot of sexual interaction. And so it got into that population. So this is, what we're seeing now, and the reason why that 98% of the cases are in the MSM community. That doesn't mean that there's any sort of protection against heterosexuals, that they couldn't get monkeypox virus. It just happens to be where the virus is circulating right now. Whether we call that truly a sexually transmitted disease is another question. Typically we would think of a sexually transmitted disease where you have virus that is secreted in the sperm or in the semen or in the vaginal secretions. There is some evidence of virus in the semen of monkeypox in some of these men, but relatively low levels, and it's not clear that that itself is the infecting event or that's necessary. Again, you can think of it this way. I guess you could call a cold virus a sexually transmitted infection if you wanted, right? Because people have a very close rapport, and one of them has a bad cold, is probably going to pass it on to the next person. But it's not necessarily what we would call a sexually transmitted disease in the classic sense, like HIV virus or some of the others. So we're still working through that, and it has significant implications because some of the protective measures that we would normally advocate for a sexually transmitted disease may or may not be efficacious to limit the transmission of monkeypox. And so, that's not just a question of semantics. It is a question that needs to be answered. So, for example, to be very clear about that, when we talk about HIV, we talk about having safe sex with condoms. Would safe sex with a condom protect against monkeypox virus? It's not certain because, of course, there can be lesions. There can be lesions on the genitalia, but there can be lesions in quite a few other areas of the body. I should mention a journalist asked me about this the other night and said, how would anyone ever have sex when they've seen the pictures of how terrible this disease can be? But most of the cases that we've seen so far outside of sub-Saharan Africa have, first of all, they have been of the West African clade or strain, which I mentioned earlier on, is the less pathogenic one with a relatively low case fatality. And many of the cases at least have been quite mild. And so rather than the more horrific pictures that you've seen of people just covered with lesions, we've often seen cases with just a few lesions and not necessarily as sick as some of the people that we've seen in sub-Saharan Africa over the course of the last few decades. Having said that, I did mention there's been, there have been deaths, 9 deaths so far, 2 in Spain. I think have the numbers here somewhere, but 2 in Spain and a smattering of other countries, but not many. So a low case fatality ratio. This can be more dangerous in an HIV positive population, other people who are immunocompromised, and we're still trying to have a better understanding of that. To date, as I mentioned, 25,000 cases, although 70% of those cases have been in Europe so far. The United States is the country that has numbered the most cases, somewhere around 5,500, something like that. Again, this is probably a significant underestimate of the total number of cases. Based on these events, you may have followed the news. So through WHO, there's a process for an emergency committee to meet and discuss whether this constitutes a public health emergency of international concern. I was lucky to be on that committee, and we've met twice so far. The first time, perhaps a month or so ago, and where people felt a little bit more reserved and thought it was not quite ready quite the moment to declare that. But a week or so ago, a little more than that, I guess now, there was a second meeting of the committee, and Director General Tedros of WHO did declare this a public health emergency of international concern. It's another topic that I won't go into detail here today, but there's a whole question of that whole process of declaring a public health emergency of international concern. Certainly helps in some ways in terms of raising recognition. Sometimes in the past that it's hurt in terms of inappropriate travel bans that have been implemented. And so that whole process is really under review by WHO. So then the question now is, what do we do about this? And so what are the mitigation efforts? What are the tools that are available to us? I would say that the number one tool that we need to approach is really behavior modification. And so again, we know that this is a disease that requires close physical contact that can be avoided if one chooses to avoid it. We need to have a better definition of really what that means. And can people have sex, for example, safe sex with a condom, or is that still not protective? We don't really know. So I think that's the number one question, is how do we use some of the behavior modification and what the uptake is of that. Working with populations right now in the MSM community. We shouldn't feel that this is necessarily or will be in the future confined to the MSM community. It certainly can get into the general population. And it doesn't mean that it's not important, of course, and not something that we have to take extremely seriously, that it is right now confined mostly to the MSM community. So I think there's a lot of questions about the behavior modification and how we get the right messages out there to the right people in a non-stigmatizing way. And then, of course, some of the other tools, diagnostics. This is not a particularly difficult virus to diagnose in some ways. The sample type is a little tricky. You need to scrape the lesions and then send basically that crust to a laboratory. Once it gets to the laboratory, it's not that that's particularly difficult. It's some of the common diagnostic techniques that you've probably all heard about in PCR that can be done. Nevertheless, this is not a virus that all labs are set up to do, and you've seen it's been slow in the United States and some other areas of the world to be able to do this. Not because it takes a genius or incredible expertise to do this. It's not that it's rocket science, to use the kind of common term, but it's just that the labs are not necessarily set up to do this. This was not a common diagnostic that needed to be done, and a lot of the logistical efforts. And so initially, this was set up in the United States to be specifically through CDC certified laboratories. And so there were a lot of things that slowed the process down. And I think the US has taken steps more recently to speed that process up. But so we do have diagnostics. That doesn't mean the diagnostics are available in every country in the world. And so we still have considerable pipeline issues of getting diagnostics to laboratories in sub-Saharan Africa. I should note that although we've had 25,000 or so cases, most of them in the high-income countries of the global north, since 2000, in the beginning of 2022, somewhere in my notes I have the exact number, but we have something like 300 cases that have occurred in sub-Saharan Africa, but with considerable number of deaths. And so this is not something that we can say is not a problem. And we come back to the tools that are available that are largely, and I hope that we will not be completely playing the same record that we did with COVID, but tools that are not necessarily available to our colleagues in sub-Saharan Africa, where ironically this disease is endemic and has been for 50 years or so. But so diagnostics, a lot of things to work on. One of the thing, and Ellie, thank you for your kind words about FIND, the organization that I work for here in Geneva. One of the things that we've been working a lot is to try to make sure that there's a lot of interest in getting the right tools. And so rapid diagnostic tests, similar to like you all used for COVID, for example, could you do that at home and put that on a little cartridge that a line would show up and tell you if it's positive or not. But those are not really out there in terms of any validated way just yet. And then vaccines, there's been a lot of discussion about vaccines. We need to go back and recognize that virtually all the data that we have for monkeypox has been extrapolated from smallpox. And there's no more smallpox in the world, fortunately. But this research has not really been done in collecting large number of cases and being able to test for these vaccines in sub-Saharan Africa. They haven't been used in sub-Saharan Africa. And so there's a lot to do in terms of understanding the vaccines and the newer generation vaccines that are really the ones that are used now. It should be noted that this was all the advances that have been made for this disease come either from our concerns about smallpox when it was still circulating in the wild, and then from concerns about bioterrorism. So after the anthrax outbreaks in the early 2000s in the United States that were, of course, bioterrorist events, there was a lot of concern that smallpox could still be found, the virus could still be found and used as a bioweapon. And so that's really what's promoted the use of these vaccines and the development of these newer generation vaccines. But they're all tied up to a degree. This is changing slowly, but they're tied up in a degree where in stockpiles that were meant for biodefense, not necessarily available on any open market. Some changes are happening there. And then there's a lot of questions about strategies. We have significant. First of all, we have significant supply issues. I think there will be significant supply issues, although the lone maker of the vaccine that's in play right now, Bavarian Nordic in Denmark, has ramped up their supply. And nevertheless, it's going to take some time into late 2022 or 2023 to probably have ample supply. It depends, of course, how we use it. And there are big questions about the target populations and how do we use it. So the classic way would be post-exposure prophylaxis. So for example, if someone were to say, okay, I had sex with someone who had monkeypox, then we know in the immediate aftermath of that exposure, we could give that person vaccine and prevent at least severe disease. There's pre-exposure prophylaxis, and so defining populations at risk and saying, here's a high-risk population that we should give the vaccine to. But it's not clear how these would be implemented, and there's a lot of different strategies that are developing in different countries, and also that are trying to deal with the supply issue. I can tell you, for example, here in Switzerland, there is no vaccine that's available yet for monkeypox. And then lastly, I'll note that there's a therapeutic called tecovirimat that is also out there for smallpox and monkeypox, but we still need more data, I think, on that because this has been hard to study. I see, Ali, that we're probably at time, but I'll give it just a few last comments on.
Oh, please do.
The key messages and then some of the key knowledge gaps. So key message, we really should not be surprised at what's happening. And, as I told the story of this virus, as it's developed over the years, we have to recognize, and I'll put it in the chat actually, and if you could pass it on, a piece that I published in the Telegraph in the UK, an op-ed piece a few weeks ago, and really recognizing that this is a harbinger of what's to come. So this is not a one-off. This is something that is going to happen, whether it's monkeypox or other things. The idea that there are remote diseases in some parts of the world that are not our problem if you don't live there, if that was ever true, that it really is over, because we have a very connected planet. We'll continue to have a connected planet, and whether it's monkeypox or something else, we have to recognize that. And both ethically, but also strategically, the way that we need to approach this, of course, is not waiting till it gets out to a high country or someplace where we, for whatever reason, get more concerned, we need to approach this in the area where these diseases are endemic. And we need to make sure that with our activities now, that they're not all focused on just what's happening in the United States or Europe or wherever it may be, that we need to get back to the root of the problem and where people are suffering most from this disease, and that is again in sub-Saharan Africa. So I think we need to recognize that COVID was a wake-up call for this. Monkeypox is a reminder; it will not be the last. That shouldn't be something that is incredibly depressing to people. We have the tools to deal with this. We just have to decide and find the political will to do it. And we should also recognize that we have picked up this monkeypox outbreak, right? So it's not perfect. There are always missteps. There's lots of things that could be done better, should be done better. That's true for this time. It'll be true for the next time, but nevertheless, we don't have a virus that is circulating for years in a place and no one knows what's going on, or no one has a diagnostic test, or understanding that at all. So I think that we shouldn't look at it only as bad news. There's some good news, but it comes back to really preparedness, and it's preparedness needs to be focused not only on the high-income countries, but also as a global effort. And then lastly, with key messages, I guess there's concerns about whether this will become an endemic disease. So is this a sexually transmitted disease that will be with us forever? I think it's too early to say that. There's some positives, if you will, and how we can escape that situation. And because probably from the data that we have, once you have monkeypox, you're probably protected for, if not life, for a good long time from reinfection. You're only infectious for a period of 3 or 4 weeks in most cases. And so if you have this disease and this virus, once you get better, probably you're not going to pass on to anybody. So I think that remains to be seen. But our mission now, of course, is to react to this problem on a global level. And then I think I probably don't need to go too deeply into some of the knowledge gaps, but you can garner them, I think, from what I've said today so far. But we still have some work to do to understand the right sample types and the best diagnostic assays and validate those and make sure we have pipelines and ideally rapid diagnostic tests. Also recognizing that this is a virus and a disease that in sub-Saharan Africa is usually seen in very remote rural areas. And so, there's not necessarily, even if you have a good PCR test, it's probably not going to be next to where the patient is. And so a rapid diagnostic test would be incredibly helpful. Lots and lots of work to do in terms of the vaccines and understanding really how the data that we have on smallpox can be extrapolated, if it's appropriate to extrapolate for monkeypox. I think we have reasonable data from studies from looking at antibody levels that are comparable to what we saw from in smallpox and monkeypox once you're vaccinated, and some data from non-human primate studies in monkeys that show that this is effective. But I think we have a lot to do there. And then deployment, how best to use the vaccine and post-exposure prophylaxis, recognizing that many of the people who might be exposed may not come to clinical recognition, and so that might be difficult to try to find those people and to vaccinate them. And then just different, and we had a long discussion at WHO yesterday about the right sort of formats for clinical trials and vaccines. How do we really know if they work? And we have to think about some of the biases and some of the difficulties of populations and how we do that in case control and other studies. For example, if you vaccinate the people who are perceived to be at the highest risk, then you may the results may be influenced by either a clinician or a particular vaccinee really goes out of their way to get vaccine because they're at high risk in terms of their behaviors. And so that may not be indicative of other people who have lower risk. So lots to work through, I think, on the research front. Lots to make sure that, again, to reiterate the point that research needs to, and the benefits of that research need to be global, and that we're addressing this not only in the United States and high-income countries, but also in sub-Saharan Africa. So the last thing, just while I have the mic and before we go to discussion questions, is I would be remiss if I didn't make a shameless plug that if you're interested in these issues, do please join us for annual meeting of the American Society of Tropical Medicine and Hygiene. Ellie mentioned at the beginning that I'm privileged to be the president of that society right now. We look forward to see you at our annual meeting in Seattle, Washington at the end of October, beginning of November. So I'll stop there, Ellie, and happy to take any questions and initiate whatever discussions you'd like. Thanks.
So my first question, Dan, is, are the worried non-scientists invited to the annual meeting? Or is it really reserved for folks that are scientists in the microbiology realm and the other relevant disciplines?
First of all, I want to point out that I did not plant this question. Ellie just came up with it on her own, but no, anyone can join the meeting. Of course, it is oriented towards scientists, and if you don't work in the science, there's many sessions that honestly, would probably be over your head. However, this year there's a particular focus on health and human rights, and so I think that's something that many people could tune into. And there's quite a bit on policy and high level things. So you don't have to be a science geek or have any particular degree. Anybody is welcome, and I would encourage you. It's not quite out yet, but very soon the program will be out online, and so you can go and take a look at that and see if it's your cup of tea. But yeah, we welcome all who are interested in Seattle.
Perfect. Well, I'm a geek who loves science. I'm not a science geek since I'm not a scientist, but there's some really good questions in the Q&A. I just wanted to ask one. What we have heard, at least what I've heard, is that as tragic and catastrophic as COVID-19 has been, at least we had a grounding in lots of research around coronavirus, the coronavirus family, to give us the basis for rapid development of vaccines, et cetera. And that what we need to do as a national security and a global security kind of an effort is to fill knowledge gaps for the viral families for which we are not as knowledgeable, about which we are not as knowledgeable. And one question is, Dan, how long would that take if we could gather the resources and there was really a collaborative effort to get at the answers we need? Is there any sense of how quickly we could become significantly better prepared for other viruses? I know this is a little outside the monkeypox realm, since it's hard to imagine that becoming a pandemic. But
yeah. No, that's I think is really the question that needs to be asked and needs to be acted on. You may be familiar with an organization called CEPI and
yes.
Movement, that initiative that came out of the UK from the last G7 meeting about a year ago, called the 100 Days Mission. And the 100 Days Mission is exactly that, Ellie, that the challenge of within 100 days of the announcing a major event of a pandemic or epidemic, can we have the right tools, that's diagnostic, vaccines, and therapeutics ready to go? So CEPI, which is UK and Oslo based, has been taking the lead really on the vaccine part of that for quite some time now. And Richard Hatchett and his very skilled team. That doesn't mean there's no one group, right? This takes collaboration on a global level, but CEPI has been leading that. So FIND is really working very carefully on the diagnostics part of that. And then of course there's the therapeutics end as well. I would say that right now, of course, no one would claim that within 100 days we could be ready to do that. The approach of most of the organizations in terms, including FIND, is really to have prototype vaccines and prototype diagnostics ready for different virus families. There's different processes that are ongoing right now, and a lot of debate on what those families should be, and trying to figure out, where the real risks from different virus families. So what we'd like to be able to do, for example, say, here are the 10 virus families that we think are the most dangerous to us. And then let's pick the most dangerous virus in that family and make a prototype vaccine and a prototype diagnostic and a prototype therapeutic. And so be relatively ready for that. And then with the principle and the thought being that then pivoting if it's a virus that's maybe not that one, but quite similar, that we're pretty close because we have a lot of data on a very similar virus. And indeed, that's why we were, everyone talks about how terrible COVID has been. And of course it has been, but it could have been worse. And the reason that it wasn't worse, the reason that we were able to respond to COVID relatively rapidly in terms of the development of vaccines is because we had the SARS outbreak in 2003.
And 2000.
And so the work on coronaviruses and recognition of coronaviruses as a global threat. Same thing with the large Ebola outbreak that happened in West Africa in 2013 and 2016. The reason that we have 2 licensed Ebola vaccines right now, for which we do have data, is because we were concerned about Ebola as a bioweapon. So there was a lot of advanced research that was done for Ebola, and now we have vaccines, and we have a couple different therapeutics for which there's evidence of efficacy. Using all those tools is not easy, but nevertheless, and so that's what we need to do is we need to put in that advanced work for a broader group of viruses and be ready then when they should appear.
Well, we have a lot of great questions I see in the Q&A. So Sam, if you could join us, and while you're joining us, one more lightning round question on that. Is the U.S. a donor to that effort?
Yes.
Okay.
There will be people who should say that there should be a larger U.S. contribution to that effort, but U.S. is a donor to that effort. The effort, nevertheless, is still considerably underfunded. The replenishment process for CEPI maybe 6 months ago, is it now? The budget was 3.5 billion, and I think the pledges were around 1.5 billion. So there's still quite a bit of advocacy to do. It also came right at the time when the Ukraine war was starting, and we do recognize, and I'll have to recognize that resources are always limited, right? And so that becomes challenging for us, but it's also always more expensive to clean something up, both in terms of money and lives after it happens.
Yeah. I know we'd love to see NIAID, have more resources since it plays such a leadership role globally in this. And so, but anyway, Sam, let me shut up now and you go ahead. They're great questions. I love Kristen's question. I love all of the questions.
Yeah, absolutely. And thank you so much, Dr. Bausch. This has been so informative, the conversation so far. So we have a question from our audience. How should we be thinking about protecting the healthcare workforce? Is the close contact associated with caregiving a risk factor?
It's a great question.
Good question, and always a pertinent one. So there have been to date somewhere around 300 cases recognized in healthcare workers. Most of those healthcare workers, from the data that we can garner, would say that probably it's more community transmission than their job as a healthcare worker. So we're not seeing, as far as we can tell, the sort of thing that we saw, again, going back to the Ebola outbreak, where there were lots of people getting infected and tragically dying of Ebola. But nevertheless, people on the front lines, I think that most of the strategies for vaccination would include healthcare workers in particular settings. And this one, it would be sexual health clinics and things like that would be on the first order, in terms of being vaccinated.
Excellent. And kind of along those lines with vaccinations, we have another question. Could you comment on the role of residual immunity in older communities from previous smallpox vaccinations? Should this influence priorities for limited vaccine administration among those that are exposed?
Yeah. So it's a great question. Again, we don't have a lot of data. We know that smallpox vaccination, variola vaccination that was used up until the declaration of eradication confers long-term immunity, but what long-term is. And so what we, people who are older and receive that vaccine, so are they still immune? We really don't know it. So there's some work that needs to be done there. One of the challenges and the way that we term that is the correlates of immunity. And so what we like to be able to know is, okay, have good data where if a person has this level of antibody in their blood, for example, that correlates. We have clear evidence that if you're at that level, then it's good and you're protected. And if you're below that level, then you need a booster. But we really don't know that yet. We are seeing, as I mentioned, if we looked at the epidemiology of monkeypox as it's gone over the years, the initial cases were very young people who, of course, were not vaccinated. They were They were young and just after the cessation of vaccination, so they were not protected. And so the initial cases of monkeypox were in very young people who were the susceptible ones. And then as time goes on, then we see that grow into an older, not old, but older group. So a key question for which more research needs to be done.
Absolutely. Excellent. So another question we had come through, do we have any information on why the fatality rate in Africa is higher during this outbreak than in Europe and the US?
Well, first of all, we have to be careful not to mix the two clades or data from the two clades, right? And so, as I mentioned, the Congo Basin clade is a more dangerous virus. And so not all, but many of the deaths that we've seen in sub-Saharan Africa are from that Congo Basin clade. All the cases outside of sub-Saharan Africa to date have been with the West Africa clade, which is less dangerous. Nevertheless, we have seen deaths in Nigeria from the West African clade. We don't really know what those are due to specifically. They've been fortunately relatively few, but I think that we can postulate that perhaps immunocompromised. It's not just a question of being HIV positive. It might be a question of it being HIV positive and uncontrolled HIV, people with very low CD4 counts, for example, who are quite susceptible, or other predisposing conditions in terms of malnutrition or other chronic diseases. So probably related to that, but again, more data are required. There's certainly a lot of people amongst the population of the MSM community infected outside sub-Saharan Africa who are HIV positive, and so we're not seeing huge numbers of deaths and high case fatality in that group. Many of those people may have their HIV under relatively good control, and so that may account for that. That's speculative, but I think that would be one way to understand it.
Great.
Excellent. So another question we had come in, what should be the recommended isolation period once infected, and what should isolation look like? Masks, touch, laundry?
So another good question. So a couple clear things. So this is not COVID and this is not Ebola, right? And so there's not a reason to have people, they don't need to be in strict respiratory isolation, but nevertheless, a person who does have monkeypox should be isolated. That should be essentially, to put it in very simple terms, it's isolation to prevent direct contact with the person, but also direct contact. There's evidence of both smallpox and monkeypox viruses because the virus is in the crust of those lesions. So a person, the bed sheets and the clothes of that person can also spread the virus, and so there needs to be isolation from the person themselves and also from the other things that the person may have touched, but not negative airflow and things like that.
Thank you.
Great.
So another question we have, do you think if we can detect the lesions before they appear, more people will get diagnosed without shame?
So I'm not sure how we would detect the lesions before they appear, because then I'm not sure what sample you would take. And it's clear that really where we find the most virus is in those lesions. So if you were just to take a swab of the skin where there's no lesion, we wouldn't really get a positive test even for the person who has monkeypox. There's nevertheless some interest in research that's ongoing in trying to figure out, that's a relatively difficult sample to take, to have to take the crust and scrape actually the base of that lesion is what you try to do. That's not what we would prefer. We'd like to be able to figure out, can we, for example, get this out of an oral swab in a similar way, or a nasal swab in a similar way that we've done for COVID. The data are just not in yet, and still, so the recommendations are really still for the crust, but I don't think it would be from a general lesion on the skin. Probably the most promising alternative sample type would be a throat swab, but we need more data.
Understood. Understandable. So another question we have, are there tactics being implemented to battle misinformation for now? And as more data comes in, is there anything that we can do to help that?
Great question. That is kind of the challenge of our day, right? And so there's misinformation. And if you go on Twitter or anywhere, you see a lot of terrible things and a lot of stigma. But I think we just need to keep pushing back on a couple of different issues. First of all, the human rights to health and the ethical issues and inclusion and respect. And I think, and so that's these are principles that all I can say is that, they have to be something that good people need to stand up for at every opportunity. And then we need to stand up for science, right? And so we've had a lot of doubting about science, and it's okay to doubt the data. That's the scientific process of doubting the data, but we shouldn't doubt it just because it comes from a scientist, or we shouldn't doubt the scientific process. There is scientific truth. It's sometimes difficult to get at, but nevertheless, there is scientific truth, and we should respect and promote that process. And when that process is respected and we go through it, then we need to adhere to it.
And I think it's also important for the science community to distinguish between vaccine hesitancy that may be based on risk calculations, kind of like playing the lottery and thinking you're going to win. My chances of winning the lottery were pretty much the same if I bought a ticket or didn't, So I think we really have to distinguish between kind of a feeling of scientist and science isn't legitimate, and I'm scared.
Yeah.
I don't have high risk tolerance, and I'm scared, and I need you to help me feel less scared. So I think it's really important, because I think those two factors about risk tolerance and misinformation sometimes get entwined in really unproductive ways.
Yeah, and it's very difficult. It's for all of us. I think it's hard for us not to be judgmental about the people who have different viewpoints, and so that's difficult for us to do. But it's very clear, if we look at COVID, we'll see how things with monkeypox play out. But the science in many ways has been great, right? We were able to establish diagnostic assays and tests and vaccines, and to a lesser degree therapeutics for COVID in quite a rapid time frame. And so I think we have tools for monkeypox as well. So our biggest challenge has not necessarily been a scientific one, which isn't to say that we don't need more investment in research and to keep up the scientific process. We can't take our foot off the gas there, but nevertheless, we need to recognize that the science, the data in and of themselves, and the product in and of themselves, as the people have said, it's not vaccines that protect people, it's vaccinations, right? And so we need to make sure that these tools get used, and then I'll always come back to make sure that the tools get used to in an equitable way in populations across the world. And so there's still a lot of work to be done there.
And Daniel, do you have time for one more question before we wrap up?
Sure, no problem.
I know we're behind. I mean, truly, you tell me no.
No worries.
It's happened many times. So I wanted to, we missed Tina's question, I believe, and I wanted to make sure we got to it. And I could be wrong there. Did Sam, am I?
No, I think you're correct there. So we have a question. What do we know about the efficacy of the vaccines and antivirals against monkeypox? Are there ongoing clinical trials to assess that?
So there, I would say better that there's ongoing discussion about clinical trials. There was a 5-hour WHO meeting on this yesterday to talk about clinical trials and monkeypox vaccines. It's not simple, really. That we have a couple different challenges. First of all, supply, depending upon how we decide we want to use the vaccine, supply is an issue, right? And the Jynneos vaccine, it has different names if you go to Canada and so in Europe, but Jynneos in the United States is a relatively new vaccine. As I mentioned earlier, it's been approved for monkeypox, but that's based on some antibody data in non-human primates. It's not based on any efficacy trial or phase 3 trial looking at that vaccine for monkeypox, because of course, how would you do that trial? No one has gone before May 2022. You would have to go to remote places of sub-Saharan Africa and do that. And perhaps collectively, of course, we should have done that, and we should do that now. But nevertheless, that did not happen. And so there's a lot of questions. Some of the research questions are so do we need to approach, since that's a 2-dose vaccine, so day 0 and day 28, and since supply is a question, what do we get, for example, from 1 dose? What's the protection that's conferred from 1 dose? What if we fractionate doses and use a lower dose? What if we the normal vaccine is given subcutaneously, sometimes intradermal vaccination where it's injected into the skin? can produce greater immunogenicity. And so there are a lot of questions about how to use that vaccine. The scientific questions, if I can group it as such, and then, as I mentioned earlier, then the deployment questions. It's certainly not a vaccine, even if we wanted to, and there would be no indication right now to vaccinate the population in general. Right? We have a disease that is in a relatively focused, defined population right now, so that we can identify risk. It's not whether you're gay or straight. It's kind of what your behaviors are and what your circles of contacts are in a non-judgmental way. And so we can define a population at risk right now. And so, that's really where we need to use it. But is it pre-exposure prophylaxis, post-exposure prophylaxis? We all recognize that there are certainly many cases, and I think many people who are exposed that we never get to, never come to clinical recognition. And so if we were just to say, okay, we're going to use it as post-exposure prophylaxis, if we can only get some smaller percentage of the people who are actually exposed vaccinated, then then we have it might not be as efficacious as we'd like it to be. So a lot of questions of things that need to be done in the lab or need to be done through formal trials, but a lot of questions about what the right deployment strategies are. And it probably won't be one size fits all, right? There's different cultures in different countries and different places. And so, what works in Spain might not be the same thing that works in the United Kingdom and the same thing in the United States. But these are very, very active ongoing discussions right now.
Terrific. Thank you so much, Dr. Bausch. Dan, Daniel, I think I've called you pretty much everything possible. You've been terrific. We had a big audience, and that has everything to do with your ability to address this topic, which has really been confusing for a lot of us and worrisome. And so thank you. And we'll be inviting you back.
Okay.
Don't ignore my email.
Great. Have a good afternoon.
Okay, we just want to wrap up by talking about an Alliance member discussion next week. It is August 8th, which I think is Monday.
Actually, August 9th.
9th, I'm so sorry, August 9th at 11. Here it is right in front of me. This one's going to be really important for advocates to attend if you can. We really fully anticipate that in the next Congress, there will be a significant focus on oversight, and NIH, all of the agencies that we advocate for at Research America are likely to be really under a very intense spotlight. And so Grace and Kristen, who are both really thoughtful staff of Representative McMorris Rogers, who is right now the ranking member of the Energy and Commerce Committee, jurisdiction over authorizing for NIH, FDA, CDC, ARC, ARPA-H. The only one that I'm missing here is NSF, and that is under a different jurisdiction, different committee. They're going to be joining us to talk about what next year might look like, and I hope that you can join us for that. And Sam, let me turn to you for any housekeeping I'm missing.
Of course. So we have two additional pieces of information for you all. Our 2022-2023 Civic Engagement Microgrants are open. So please share this with your civic scientists out there. The deadline for applications is the 31st of August. And our annual National Health Research Forum is also open for registration. We will be holding this on September 19th through the 21st. And there I will put a link to register for our forum in the chat right now. And those are our last two pieces of housekeeping.
Great. Well, thanks again to everyone who joined us. Join the Alliance if you're not a member. But do join us next week for this Alliance discussion. Your questions are going to be really important for this discussion, and hopefully this will help guide us in our advocacy in the next Congress. So with that, have a great rest of the week and see you next. Bye.